Karo wong Amerika, orangnya aku golek bengi lah kan, karena kan jam 8 iso.
Okay, good morning for you in the United States and good night for you in Indonesia. Welcome to Global Health Webinar Series. I'm Ari Probandari, the moderator of this webinar. This webinar is a collaborative project between Universitas Sebelas Maret Indonesia and University of Texas, San Antonio, United States of America. This first series of the webinar will be divided into two sessions. So tonight is the first session. In the first series, we'll take a theme of policy issues in women health. Tonight we have the presentation session, and by next week, on Wednesday, 27th of October, we will have a question and answer session. Tonight we will hear two distinguished speakers, Fitri Widyaningsih, PhD from Universitas Sebelas Maret, and Jusung Lee, PhD from University of Texas, San Antonio. Before we hear the talks from the two distinguished speakers, let us hear the opening speech from Professor Lynn Kausman, the Dean of College for Health and Policy. Prof. Kausman, time and screen are yours, please.
Thank you. Good morning and good evening, everyone. This is so fantastic to be at our first webinar between UNS and UTSA, and I'm excited to hear what the speakers have to say about maternal health in both the United States and Indonesia. I think there is much to be gathered from this collaboration. It's a brand new collaboration. We are, for those of you who don't already know, we are a brand new college at UTSA, the University of Texas at San Antonio. And our college's mission is to improve the health and well-being of people in our community, state, nation, and around the world. So this collaboration is particularly key to our, excuse me, to our mission. This collaboration was started because I have a very dear friend who works at UNS, Dr. Abdul Rahman, who I went to graduate school with at Florida State University 3 decades ago, which just goes to show you that these sorts of collaborations can come from anywhere at any time. And I hope that this series of webinars and our collaboration with UNS will lead to many research projects and teaching opportunities that will join our two universities together. Thank you, Ari.
Thank you, Professor Kausman. Now let's hear the talk, the opening speech from Professor Reviono, the Dean of Faculty of Medicine, Universitas Sebelas Maret. Please, Professor Reviono.
Thank you, Prof. Ari. Okay, Dean and College for Health, Community and Policy, Universitas Texas, San Antonio, Professor Lynn Kausman. Our distinguished speakers, Dr. Jusung Lee, Dr. Fitri, and Prof. Ari Probandari. And also our respected audience and all committee of this webinar, our 100 guests and participants. Assalamualaikum warahmatullahi wabarakatuh. Good evening, good morning. Welcome to our webinar. It is with great honor that we are here today to attend this webinar, collaboration between Faculty of Medicine of the Universitas Sebelas Maret and College for Health, Community and Policy, University of Texas at San Antonio. We hope that this webinar can be start to build collaboration, extending networks, and generating ideas for future works, as in our dream to contribute to global health. Today's webinar topic, health policy issues in women health represent one of the main problems we are still facing today. Indonesia still has high maternal and child morbidity. Hence, improvement in access and quality of maternal health care to improve women and child health is important. We hope that through this webinar, we can share experience on women and maternal health. In addition, can provide learning opportunities on the women health program and policy both from Indonesia and US perspective. Okay, ladies and gentlemen, we hope this collaboration will continue with further activities and will be beneficial not only to collaborating institutions, but also to the community in both countries. Thank you. Assalamualaikum warahmatullahi wabarakatuh.
Thank you very much, Professor Reviono. Now, before we hear the talks from the two distinguished speakers, let's have the group pictures. Please open your camera, give your best smile, and we will have a very good picture of us to start our collaboration between Universitas Sebelas Maret and University of Texas, San Antonio. Okay. Someone can account.
My God. 1, 2, 3. Time.
Okay.
1, 2, 3.
Okay, thank you very much, Astrida. Okay, now we are coming to the first talk from Dr. Fitri Widyaningsih. Dr. Fitri Widyaningsih is an epidemiologist. Now she is an assistant professor working with Faculty of Medicine, Universitas Sebelas Maret. She earned her medical doctor at Universitas Sebelas Maret and then continue with master and PhD in epidemiology in Michigan State University, United States of America. And her research focuses on social determinants of health for various health outcomes, including non-communicable diseases and maternal and child health. Please, Dr. Fitri, you can have your talk for 20 minutes.
Okay, thank you very much for the time, Professor Ari, and thank you very much for Dr. Lynn Kausman, Prof. Reviono, and also Jeffrey Howard, and also all the sister group for making today's webinar possible, and also my collaborator in this webinar, Dr. Chu Sang Lee as well. I'm going to start today's talk, but first let me share my screen. Okay, I hope you can already see my screen now. Yeah, so today I'm going to present about maternal health program and the path to skill delivery in Indonesia. As Prof. Reviono mentioned, and also as Dr. Kausman also mentioned, that women's health, including maternal health, is still a problem, not only in Indonesia actually, but also in the United States. And later on, Dr. Chu Sang Lee will also highlight about these problems. And there have been several programs that has been initiated. And today we're going to learn how this program actually affect maternal health care. And for my perspective, it's from the perspective of Indonesia. Before we start, let me introduce you, especially from those from United States, about Indonesia. So this is Indonesia. We are an archipelago. We have over 13,000 islands, although only half of those actually inhabited. And as you can see here, we have 5 main islands. And in these 5 main islands, there are actually differences. You can see here the color here, it represents the density of the population. And if we see the 5 main islands here, we see that the most densely populated island is actually in Java. And this is also the most, the island with the most advanced infrastructure as well. And in other area like Sumatra is also second in regards to density, but you can see that in other islands, it's less dense in terms of populations. And regarding maternal health, Indonesia ranks 5th in the highest number of maternal mortality. Almost half of Indonesian women actually reported maternal morbidity during pregnancy or labor. And to improve this condition, one of the most important things is actually to improve access and also quality of maternal health care. And in Indonesia, we see that utilization, we're going to learn how utilization has been progressing throughout the year, but we still see differences in utilization, particularly by economic and geographic conditions. We have several maternal health programs that has been implemented in Indonesia. We have in early 1990s, the village midwife program. And this is a nationwide program in which midwives is being sent to the village and they're actually living there to serve the population in the village. And then in 1998, we have the government launched what we call the Alert Campaign program. So it's actually a program where you're trying to improve awareness of the community about maternal health. So whenever a woman is getting pregnant, the community needs to ensure that the woman can have access to healthcare and they can have the support they need, including, for example, transportation if they need to go to the hospital. And then in 2005, we have the social health insurance program. And this is insurance that targeting the poor. So these 3 programs with their different characteristics is providing us a window of opportunity to see what kind of program actually affect maternal health care utilization. And from previous studies, we have seen increased coverage of maternal health care in Indonesia. However, few have assessed how the progress in maternal health care is related to the initiation of maternal health programs. So in this study, we're going to see how the trends and how the changes happen after the initiation of the 3 maternal health programs that have been implemented in Indonesia. And we're going to focus on skilled delivery. And this is first, what we call skilled delivery is birth or delivery attended by skilled healthcare provider or happen at the healthcare facilities. And we have seen limited evidence on how the programs affect different groups or regions. So as I mentioned before, in this presentation, we're going to show you the progress in skilled delivery, and we're going to show this progress by wealth and region in relation to the initiation of the 3 maternal health programs in Indonesia. So we will see how progress in healthcare utilization in terms of trends in increase, and then also how these differ by wealth as well as by the different region in Indonesia. For this presentation, we use secondary data from the Indonesia Demographic and Health Survey. And this is a cross-sectional survey conducted every 3 to 5 years in all provinces in Indonesia. And this is a nationally representative survey and a relatively large sample size. And sample include women who had at least one live birth in the 5 years preceding the IDHS survey. So you see here we're using 6 IDHS survey years, and we have over 80,000 women included in this analysis, and we have relatively low missing values on facility birth and also missing skilled birth attendance. And this is the main outcome that we're going to use. Skilled birth attendance is birth attended by physician, midwives or village midwives or nurse. And skilled facility delivery is birth happen at health facility. And this is some of the confounding or other factors that we also include. So we include, for here, main exposure is the 3 maternal health programs, and then several individual and community level confounder is also included in the study. And we have also potential effect modifier, so wealth as well as region. And we divided region here because you see that we are very different in terms of density of population. So we classified into Java, Bali, which is the most densely populated islands in Indonesia. And then we classify other islands into the more densely populated and the less densely populated other islands. And the analysis approach is using what we call segmented logistic regression. So the segment is the portion or the time between the intervention. So here you see the first part, the second part, the third, and then the fourth part. This might explain it better. So we use this modeling approach. We're going to assess immediate change and then annual trends. So immediate change, we will see that from the shift in odds directly after the initiation of the program. So here you will see that if you have immediate change. And annual trends are differences in progress of maternal health care utilization after the program. You will be able to see that in this line here. So if there's a change in slope, then we can see that there is a change in trends of healthcare utilization. So from this study, and this is the characteristic of the population that we use, from the 6 IDHS survey, we see that there are significant changes already happening in Indonesia. For example, here, age, we see that a woman who are giving birth is actually getting older, starting from 26 years in 1991 to 28 in 2012. And the parity or number of children is also getting smaller. So we started with 3 children on average per woman, and then in 2012 is 2.2. And we see here as well for age, we see that women are also getting older when they're delivering the baby. I mean, here we can see the parity as well. So parity is in 2012, more women are having only 1 or 2 children compared to in 1991. And here we see for education, women are also getting more educated. Here also only about 12% who actually have college or higher education. And this is the proportion of Java, Bali. This is still the most, where we have most population. And then here is the one from outside of Java, Bali. And more women are living in urban area. So initially we have only 29% in urban area, but then we have about 49%. And we also see progress in skilled delivery, both for SBA and SFD. So for skilled birth attendants, it was 35% in 1991, and then increased to 83% in 2012. And then for SFD, it's also increased from 20% in 1991 to 63% in 2012. And this is our segmented regression analysis that we did. So after the village midwife program, we see that there is an annual increase. So significant increase in annual trends, as you can see here. However, we don't see immediate change. Meanwhile, after the alert campaign program, we see there is an immediate increase. As we can see here, the odds is 1.3 for skilled birth attendants and 2.1 for skilled facility delivery. But we don't see the annual trends increasing significantly. And then after the social health insurance program, we see that for all women in Indonesia, there is an increase in annual trend. So we can see clear here with this picture. So this picture is describing the trends in healthcare utilization from 1986 until 2012. So here, these dots represents the proportion of women accessing skilled birth attendants. And this line here, so this line above here is the richest women, because we divide it into quintiles. And then here is the richer, this is the middle, SES, and this is the poorer, and this is the poorest one here. We see here that in the beginning, there is actually increase already without the program. But after the initiation of the first program, which is the village midwife, we see that skilled birth attendants actually increase by 13 to 15%, particularly in Q5, which is the poorest, until the middle socioeconomic status here. And this is after the alert campaign programs. We see that there is increase, but it's actually not significant as we see before in the logistic regression, segmented logistic regression. And here, sorry about this one, but here, it's supposed to be here. There is also an increase here after the implementation of social health insurance. And this is an increase by 10% for Q5, which is the lowest one here, the poorest one. However, from Q2 to Q4, which is the richer, middle, and poorer groups, the increase is almost 20%. And this is for skilled facility delivery. We see that there was actually slight decreasing trends before the program initiation. And then after the program initiation, we see after village midwife, we don't see any significant increase. And it's the same thing with the alert campaign. But after social health insurance program, we see that there is actually significant increase. And this happens in the highest of the 4 highest quintiles, as you can see here. There is also an increase here for the poorest quintile, but it's actually less than 20%. And this is comparing the progress when we're seeing by region. So before, in the previous graphs, you see for all Indonesia by socio-economic status. And here we will see by Java, Bali, more populated province and also less populated province. And from here, we can see that by region for skilled birth attendants, after the village midwife program, the increasing trends were more pronounced in the less developed region, you see here, and also in the more populated province. So compared to Java, Bali, the increase is higher in the less populated region. And after the alert campaign, there were no significant increase in annual trends. However, after the social health insurance program for skilled birth attendants, there were increase in utilization of skilled birth attendants, and this is more pronounced, particularly in Java, Bali, as you can see here. So there is an increase of more than 20% in odds per year. And this is for skilled facility delivery, so women delivering their baby in health facility. And this is for overall Indonesia, as we have seen before in the previous slides. And we see here for each area or region, Java, Bali, more populated province and also less populated province. And after the first program, which is the village midwife, sending midwife into the village, and they're able to provide healthcare there for community, including for mothers, we see that there is no significant increase except in the less populated province here. So in Java, Bali, there were no significant increase after the village midwife. And then after the alert campaign, we don't see the increase. This is similar to before, so we don't see any significant increase in trends after the alert campaign program. However, after the social health insurance program, which aims to reduce financial barrier of women to access healthcare, we see that there is increasing odds for skilled facility delivery, and this is most pronounced, or we can see most clearly in Java, Bali. And this is when we calculated is about 20% increase in odds per year. And this happened particularly in women of lower socioeconomic status. So based on these findings, we have several interpretations. So for example, the first one, women of low socioeconomic status actually had the greater changes in maternal health care utilization. And this suggests decreasing gaps in SBA and SFD. So actually the gaps in maternal health care utilization is decreasing in Indonesia. And we see from previous slides as well that programs that aims to improve physical access, and this is the village midwife, because we're sending the midwife to the village, the greatest changes actually happen in the less populated regions. And this is, we can see, because before they don't have access, or the access to healthcare is very difficult. If you remember the Indonesian geography, it must be very difficult for people in remote island to actually access healthcare. So sending village midwife is improving the physical access and is more effective in the less populated region. And then after the alert campaign program, we don't see any significant annual increase in SB and SFD. We did see immediate increase. However, we have concern that it might be the changes in IDHS survey, or it can also be a real event. And then after program that aims to improve financial access, and this is the social health insurance, the greatest changes actually happen in Java, Bali. For sure, this study have several limitations and strengths. We have recall bias, and then limitation to intercausation, because there might be some other activities or programs that happens around the same time. But we have relatively large sample size. Wealth and region assessment is also improving the way we identify groups that has the greatest changes after the program. And we also include several important confounding in this study. So based on this, we conclude that after the initiation of maternal health programs, Indonesia experienced positive changes in the progress of skilled delivery, And we see that the changes happens mostly in lower SES, particularly when you're looking at physical access, less populated regions benefit the most. But when you're looking at financial barrier, most populated region or more developed region actually benefit the most. So to sum up, there are several implications of this study. Public health, we need to further improve physical access, especially in outside Java, Bali, and then at the same time improving financial capability. And we are also looking at future research to other factors influencing gaps in SFD by well. I thank my committee because this is a part of my dissertation and also my funding as well for the PhD program. And thank you everyone for having me to present our work in this webinar. Thank you very much. And I give the time back to Ari. Thank you.
Thank you, Dr. Fitri. Yeah, I can see that a lot of undergraduate and graduate students join this webinar. I hope you can also learn from Dr. Fitri presentation about the technique for longitudinal data analysis, yeah, particularly about segmented regression. You can also post a question in the chat box. And your question will be discussed during the next session in the Q&A session. Okay, so let's hear the second speaker. Josang Lee, PhD. He is an assistant professor at University of Texas, San Antonio, United States of America. Dr. Josang Lee is a health services researcher in the Department of Public Health in the University of Texas at San Antonio. He earned master's degree in epidemiology from South Korea. And then now his research interests are mainly on individual and social determinant of health, chronic condition, and evaluation research. Please, Dr. Josang Lee, please give your talks for about 20 minutes.
Thank you for introduction, and thank you, Dr. Fitri, for your presentation. Can you see the PowerPoint?
Yes.
Yeah, I'm gonna go ahead. So my presentation is about national state health policy and realized access care among women of reproductive age in the United States. So we know that health is determined not just by individuals' health behaviors, but also health policy and programs at various levels. So in this presentation, I'm going to talk about some early results of the study I'm currently working on concerning national state health policy and how they play out in improving access to care among women of reproductive age. So women of reproductive age need essential care in a timely manner. The failure to meet the need for health services can result in poor health outcomes, such as unintended pregnancies, complications during and after pregnancy, and many other health problems. In recent years in the United States, women's reproductive health became national health issues. Among those, realized access care is a critical area for women to have a needed care and improve their health status. So this study investigates the impact of the national health policy, namely Affordable Care Act Medicaid expansion, on realized access care. The US remains above other economically developed countries in terms of women's reproductive health, such as preterm delivery rate, low birth rate, and maternal morbidity and mortality. Furthermore, women's health during and before or after pregnancy can significantly affect fetal health and development. To prevent those negative health outcomes, the CDC and American College of Obstetrics and Gynecology all advise preventive care and quality health services to improve women's reproductive health. However, despite the recommendation from the health community, many women were experiencing barriers to accessing those services. One of the significant barriers is inadequate access to health insurance. According to Guttmacher Institute, a leading research institute on women's health issues, in 2012, about 20% of women of reproductive age in the US didn't have any type of health insurance. When it comes to low-income individuals, more than 1/3 were without any health insurance coverage. So this tells us that these women lacking health insurance would have limited access to care. The good news was that under the passage of the Affordable Care Act, Medicaid expansion was formulated to reduce uninsured rate and increase preventive and essential care. However, eventually, the Supreme Court allowed an individual state to decide whether to opt in Medicaid expansion or not. Given the goal of the ACA and its Medicaid expansion, it is important to understand whether the policy intervention has been effective in improving women's access to care. Previous studies reported that Medicaid expansion under the ACA improved access to care, including expanded insurance coverage. However, there are some gaps in the literature. There has been less focus on this topic. Previous studies looked at early years of the ACA Medicaid expansion. Also, long-term effects are unknown. So the study evaluates the impact of the ACA Medicaid expansion on realized access care among women of reproductive age. The research question is if there is significant change in the outcome after Medicaid expansion, and if the policy effect exists, whether it is sustained. The study uses a quasi-experimental design, difference in differences. This approach takes into account both policy intervention status and policy intervention time period. The intervention group is expansion states, comparison group is non-expansion states. Here I included only a few states, those in the southern part of the country, but later I would like to expand to include all the states across country. As the ACA Medicaid expansion started in 2014, the pre-intervention period is 2011 to 2013, and post-period is 2014 through 2020. With this, the study estimates the changes in the outcome in the intervention group compared to comparison group. The study uses a population-based public data behavior risk factor surveillance system, which is widely used by health researchers. The study data covers from 2011 to 2020, and the population is women of reproductive age. The outcome of the study is routine checkup within 1 year, which is an indicator for the realized access care. When it comes to access to care, we oftentimes look at the insurance coverage. So one might say that expanded insurance coverage could improve actual access to care. However, having insurance does not necessarily mean improved actual access to care. Even being insured, even after being insured, people can still experience barriers, whether they are financial or structural. The independent effect is interaction term between indicator variables of policy intervention status and the intervention time period. A set of covariates are included in the analysis. In this model, the interest is getting beta 3, which is a change in the outcome associated with the Medicaid expansion in expansion states compared to non-expansion states. In this long-term effect model, the interest is obtaining the periodic changes in the outcome. In the analysis, I conducted a descriptive analysis. I also presented a trend in the outcome for both expansion and non-expansion states. I performed a multivariable linear regression with robust standard errors by referring to the approach used in previous studies. I conducted a baseline trend assumption test. This is a baseline characteristics of the study sample. Two groups are not different in age distribution, but they are different in race ethnicity. Expansion states show high proportion of white people. Non-expansion states show a large proportion of Black and Hispanic population. Two groups are also different in education and marital status. Before looking at the key outcome of the study, which is realized access care, I would like to see the trend in health insurance coverage for both groups. Before the policy intervention, two groups were a little bit different, but after policy intervention, which is 2014, there was a significant increase in health insurance coverage among the expansion states. So based on this figure, we may say that there was a significant improvement in access to care in expansion states. This is a realized access to care. After the policy intervention, there was a significant improvement in 2014 and 2015. But after that, policy effects are decreasing and fluctuating. Before the policy intervention, expansion states show lower access to care than non-expansion states. After the expansion states show about 5.5 percentage point increase in the actual access to care compared to non-expansion states. And the adjusted estimate is consistent. So there is evidence of a significant improvement in the realized access care after the Medicaid expansion. But I also wonder what the long-term effects look like. So in 2014, there was 4.6 percentage point increase in the outcome. In 2015, there was a sharp increase, but after that, policy effects are diminishing and fluctuating. In this study, there is an important underlying assumption that the baseline trends between groups are not different. In other words, in the absence of the policy intervention, groups are similar in their trend, which is a counterfactual of what would have happened if an intervention hadn't occurred. So for this, I compare two groups using only the pre-policy period. So the estimate shows it is not statistically significant, indicating that the baseline trend between groups are not significantly different. There are some key findings in the study. The ACA Medicaid expansion was effective in improving realized access care. Overall, the expansion states show about 5.2 percentage point increase in realized access care compared to non-expansion states. However, the policy effects are not persistent. There are some significance in the study. The study examined the most recent data to reflect the up-to-date trend of the policy effects. And there is evidence of improved insurance coverage, which is consistent with the findings in previous studies. However, having insurance does not necessarily mean improved realized access care. Despite positive policy effects are not persistent. So understanding the trend is an important topic for future studies to focus on. An effective policy intervention requires continuous attention from policymakers and the public health community. This is a similar study looking at the realized access care, but this time focusing on a statewide initiative in South Carolina. A little bit about background. South Carolina experiences poor reproductive health outcomes, such as unintended pregnancies. The state is one of the Medicaid non-expansion states, and many women in the state have barriers to access to care. In response to that, statewide initiative was implemented to improve women's access to care, promote family planning, reduce unintended pregnancies by providing reproductive health services, including contraceptive consultation and birth control methods such as a long-acting reversible contraception. Now it has been several years since the initiative started, so it may be a good time to look at what has been going on in the state after the initiative. As the state was implementing its statewide initiative, it needed a comparison group to evaluate the effects of the intervention. Eventually, Alabama became a comparison group. South Carolina and Alabama are both experiencing women's health outcomes below the national average. They are both Medicaid non-expansion states, and they are both conservative states. So there are some commonalities between two states. As I mentioned earlier, it would be good to look at what has been going on in the state after the statewide initiative. But to the best of my knowledge, no study has been done to evaluate the effect of South Carolina statewide initiative. So it is unknown whether the intervention was effective. The objective of the study is to evaluate the impact of South Carolina statewide initiative on realized access care among women of reproductive age. The research question is if there is a significant change in the outcome after the statewide initiative. So the study design is the same as the previous one, ACA Medicaid expansion study. So the only difference is intervention group is South Carolina, comparison group is Alabama. Pre-intervention period is 2011 to 2017. Post period is 2018 to 2020. Except these, the methods in this study are similar to those in the previous study, ACA Medicaid expansion study. So I'm gonna quickly move on to the next section. So this is a baseline characteristics of the study sample. Two states are not different in age distribution, but two states are somewhat different in age, race, ethnicity, education, and marital status. Again, before looking at the key outcome of the study, I would like to see the trend in health insurance coverage between two states. So we know that two states are Medicaid non-expansion states. So we may think that they ought to be not different in health insurance coverage. This figure confirms what we think. They are not different in insurance coverage. This is a realized access care. This figure shows a very interesting trend. From 2011 to 2017, two states were different, but at least they were behaving in a similar way. But what happens in 2018, there was a substantial increase in realized access care in South Carolina. Thereafter, the state stays above Alabama. So it looks like that there is a significant improvement in realized access care after the statewide initiative. During the pre-policy period, South Carolina shows lower access to care than Alabama. After the intervention, the state shows about 6.4 percentage point increase in the outcome compared to Alabama, and the adjusted estimate is consistent. Although it has been only a few years since the intervention started, it would be good to look at the yearly effect. In the first year, there was a 7.8 percentage point increase. From the second year, the change stays around 5 to 6 percentage point. Again, I also conducted a baseline trend assumption test. The estimate shows it is not significant, indicating that the baseline trend between groups are not significant. The baseline trend assumption has been bad. So there are some key findings. the insurance coverage was not different between two states. However, unlike insurance coverage, realized access had an increase in South Carolina with its statewide initiative. The state shows about 6.5 percentage point increase in realized access care compared to Alabama. There are some significance in the study. To the best of my knowledge, it is the first to evaluate the South Carolina statewide initiative on improving realized access care among women of reproductive age. We also noticed that insurance coverage does not necessarily represent realized access care. State intervention demonstrates its positive role in improving access care. These findings are important and exciting evidence for the state. However, continuous provisions of health services are important to make sure the sustainability of the intervention effect. Findings will provide implications to other states. There are overall limitations or more work to be done. There are some limitations associated with the data. Cross-sectional and self-reported data have inherent limitations. In the ACA Medicaid expansion study, we need to expand to include the states across the country. It is also important to look at the outcome among the low-income individuals because Medicaid expansion mainly targeted the low-income people. In the SEC study, it does not have other critical health outcomes such as the use of effective birth control methods. So there is much work to be done. Conclusions. National and state health policy were effective in improving women's access to care. However, Medicaid expansion shows policy effects are not persistent. Understanding the trend is important to gain the policy momentum. Statewide initiative was effective, but as we have seen in the ACA Medicaid expansion study, it is important to ensure the policy or intervention effects are sustained. So continued monitoring and evaluation are important. States across the country could also refer to the findings of the study in their efforts to improve women's access to care and improve the health of women. Yeah, this is my presentation. Thank you so much for listening.
Thank you very much, Dr. Jusang, for very interesting talk. So because this is the presentation session, we will continue the question and answer in the next session by next week on Wednesday, 27th of October. If you have question, you can post in the Zoom chat. And later on, this recording will be posted in our YouTube channel, in Disease Control Research Group YouTube channel. So we hope by next week, we will have some questions from the audience, from the participants, from the students, and from our colleagues in UNS and UTSA, and perhaps also other researchers in other universities also interested to join the question and answer session. So please send your comments and questions through our YouTube channel, and you can also fill in the form, the electronic form that we will announce for you. So thank you very much for your enthusiasm to this session. See you in the question and answer session on Wednesday, 27th of October, 2021 at 8 p.m. West Indonesian time, like this evening, or 8 p.m. CDT. So I think we can end this presentation session. Stay safe and healthy. See you by next week. Bye.
Thank you.